I'm Chelsey. I am a PA. I've worked at Children's Hospital for 12 years. I've been seeing tic patients for the duration of that time, but I've subspecialized in it slightly for about a year and a half. And without further ado, we will go forward and do the thing. I have no disclosures. Kind of wish I did, but I don't. No disclosures. So what are tics? So tics are movements. They're sudden, stereotyped, rapid, recurrent, non-rhythmic motor movements or vocalizations. There are kind of two big divisions between types of tics. You have motor tics and phonic tics. Now, motor tics come in two types. Simple motor tics are eye blinking, facial grimacing, shoulder shrugging, and head jerking. Now, complex motor tics usually are not what you start with, but you can develop these later in the course. They involve coordinated movements like bizarre gaits, kicking, jumping, scratching, seductive gestures, copropraxia, which is obscene gestures, and echopraxia, which is some people can actually mimic other people's tics. And then in terms of phonic tics, now there was for a while, there was a debate about whether some of the things we do with our throat and our noses are phonic vocal tics. So everyone just said anything where you can hear it is just a phonic tic, and we threw vocal tics out the window. So we don't really refer to them as vocal tics anymore. They're phonic tics. So simple phonic tics include grunting. Both of my daughters have that one. Barking, moaning, throat clearing, sniffing, hollering, and other noises. Complex phonic tics include coprolalia, which is the obscene words, which is very infrequently actually found in a typical tic patient. Echolalia, repetition of words. Paulalia, which is a repetition of your own phrase. So echolalia is actually when you repeat someone else. So if someone will say I want to go to the park, you might say park, 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 park. And paulalia is when you say I really want to eat pizza, 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 pizza. So you echo yourself, or echolalia is when you echo other people. Coprolalia occurs in less than 10%. I actually think it's closer to about 5%, which is usually in the form of uttering obscenities. So tics. So this is how we kind of take a history on what is a tic, what is not a tic. In tics, most kids have a premonitory urge or feeling and sensation that is relieved when you execute the tic. So I'll ask the kid, when you do this, is there something that if you hold it in that's bothering you, a pressure, a push, a pull, a something, an itch? Is doing the tic, does that feeling get better? So that would be the premonitory urge of it's kind of a lot of people, someone told me yesterday, it's when you hold in a cough, that feeling gets worse and worse until you cough. So it's a similar urge to that, but kids might feel it in their eye or in their nose or in their shoulder. And that urge or that feeling or that tightness has to get relieved by doing the tic. And then it becomes kind of habituated, and then it starts to kind of be executed without using the frontal cortex to think about it. So you can temporarily suppress them, so either stop them entirely or turn the volume down, but lots of kids will tell me that they then have to get those tics out even more later. So which is why there's a study that looked at what time of day is the most frequent time of day in which kids will tic, and it's actually after school on the way home. 98% of people said that is one of their biggest tic moments is after school in the car on the way home. They have variable severity throughout the day and through the course of the year. They'll wax and wane in nature through the course of the year. Their tics, so lots of parents will kind of say they'll get a tic and then it'll go away and then they replace it with another tic. So there's weird evolving door of first they had an eye thing, then they had a no thing, then they had a lip scrunching, now they have the lip scrunching and the eye thing. So there's this weird, it should evolve over time. Some tics will stop, again, also to be replaced by other ones. You can also then reincorporate old ones back into your current repertoire. Motor tics almost always precede vocal tics or phonic tics. Sorry, I broke my own rule. I said vocal tics and I should have put phonic tics. Onset is usually kindergarten through 2nd grade. Now, I will say my 3-year-old has a tic. I think that my opinion is I think that it can typically present before that, but I think it's actually recognized because it starts to worsen in severity around kindergarten. Maximum severity is typically between 10 to 12 years of age. And then you get about 2/3 of kids will have substantial improvement by late adolescence. So what's tics versus Tourette's? So in general, it's all on a scale. We kind of, to separate them is a little bit silly. I think in some ways you can kind of get more supportive services at school if you have Tourette syndrome versus a tic disorder. So there's kind of 3 big classifications of tics. So you have a transient tic disorder, which is a provisional tic disorder. Those can usually start and usually last for a few weeks. This occurs in about 10% of the average population. So I've actually seen, so they'll have a tic, it'll go away for a few months, and then they might have it again for like a year later. I've seen that this, the data I got this from in UpToDate says 10%. I've also seen data up to saying 30%. I think personally that it's probably 30% because there's probably a lot more kids kind of doing funny things that parents kind of write off. They're probably actually a tic. So most kids with simple motor tics do not require treatment, and their tics have to have started before the age of 18 years to meet criteria. Chronic tic disorder or persistent tic disorder, you can have either vocal, phonic, or motor tics, but not both, for over 1 year. And in that year's time frame, you cannot have gone more than 3 months without a tic. So, or else if you go more than the 3 months, then you probably have like an episodic or transient tic disorder. Again, tics have had to have started before age 18. So Tourette syndrome is really just a phonic tic, a tic you can hear, and a tic you can see, lasting more than a year. And no more than 3 months in between. So really, Tourette syndrome is just chronic tic disorder with a tic you can hear. What causes tics? Short answer, somewhat unclear and probably multifactorial. Long answer, it's been described in a lot of different ways. I'll go into it very briefly here. A disturbance in the mesolimbic system, which is the part of the brain that puts the brakes on movement, leads to disinhibition of the motor system. We do know that imaging studies have found that there's a decrease in the caudate volume, a part of the brain that's involved in motor control. That is smaller in kids with Tourette syndrome. Tic severity in children with Tourette syndrome correlate with reduction in sensory-motor cortex volume. Again, these are things that have been found, but do I use imaging to diagnose kids with tics and Tourette's? No, and that is because kids without that change in caudate volume or without that change in sensory motor cortex volume also have Tourette syndrome. So it's not used diagnostically, but it's felt to be that maybe that's related to the etiology of it. There's another study using PET scanning, which found decreased use of glucose or energy in the basal ganglia. There have been a few genetic studies. There's not really been a great gene cause for kids with tics and Tourette's. We do know that it's genetic in that people who have tics often have kids who have tics, but do we have a lot of really robust gene data with Tourette syndrome? No. So this is the only time I'm going to talk about this because this is like a debatable entity, but although it's been proposed that antibodies to the basal ganglia neurons from group A strep may be involved in the pathogenesis of Tourette syndrome in some patients, there's no evidence that pediatric autoimmune neuropsychiatric disorder associated with strep plays any role in the development of Tourette syndrome. So this is not the purpose of today. This could be a whole other topic, but it is not the cause of Tourette syndrome. Again, we think Tourette syndrome is caused by a lot of different things. So who has it? Tourette syndrome is actually relatively rare. So though transient tic disorders can be 10 to 30% of the population, Tourette syndrome is actually around 0.5%. And again, that probably depends on who you read and what study you're quoting. Males are affected more than females in a ratio of 4 to 1. It's pretty similar across different ethnic groups, though there are a couple studies to say that it's rare in African Americans and sub-Saharan Black Africans. Prenatal smoking may be associated with an increase of TS. The natural history. So how does a typical kid with tics or Tourette's present? So the average age of onset is 6. Disorder is manifested or peaked by around age 11. Again, that's that 10 to 12 age where it really peaks. By 96% of people, they peak at that time. The severity of tics, again, usually peaks at 10 to 12. In a study out of Denmark, in terms of like, what does it look like years later? They looked at kids who were a little bit older, around the age of 19. Over kids at age 16, 18% of them have had complete remission, and tics were minimal in 60% and moderate or severe in 23%. So about 75% of kids will have a significant improvement around age 16. And this is an important number to think about later when I talk about the functional neurologic disorder and the tic-like movements. So for patients with persistent tics, comorbidities are present in many, and whereas people with only Tourette syndrome and no comorbidities, like what we're going to talk about later, is actually only exists in about 37% of the population of kids with Tourette syndrome. And then again, that last statement is there just saying that it gets quite a bit better with time. Comorbidities. So I'm going to talk about the most common. So ADHD is interesting. It often emerges before the onset of tics by about 2 to 3 years. OCD, which is the second most common comorbidity, actually emerges after the onset of tics. So that's an interesting finding. I think compulsions include counting, arranging, hoarding, touching, tapping, rubbing, or error checking. I talked to a kid yesterday who said that every night when he goes, or I don't think currently, but previously when he would go to bed, he'd have to tap the wall in a certain order every night before he went to bed. And he was not sure if he had OCD. And I said, well, I think you answered your own question. Anxiety is very, very common as well, occurring in about 30% of kids. Disruptive behaviors like ODD is also very common, as well as sleep disorders. And the reason I bring this up is clinically, when I talk to patients, I'll say, okay, what bothers you? So you have a couple things. You have ADHD, and let's say you have anxiety. What bothers you the most? And the kid might say, well, my tics actually aren't that bad, but like my anxiety is crippling. And so if you can actually like damper or control some of the anxiety sometimes the tics get better. So we actually kind of think about it as like a whole patient and not individual diagnoses. So it's very helpful for kids with Tourette's syndrome to have some of those comorbidities managed. This is an interesting graph that shows these on the left are just disorders, common diagnoses, and the red bar is the incidence of which that diagnosis is found in kids with Tourette's. So for ADHD, you can see it exists in 50% of the population of kids with Tourette's. If you do not have Tourette's, it exists in about 12%. Behavioral problems, anxiety is upward of 60%. In the average population, again, it's around 10%. So comorbidities are a lot of the issues we see in clinic with kids with Tourette's syndrome. I'm briefly going to talk about medications because that's not why you guys are here. The main group of medications that we use, alpha agonists, that would usually be like a 10X or a clonidine. Those I personally use they're commonly used first line. They are blood pressure medications. They kind of can calm the kid down. We don't stop and start these abruptly because if you are on a high dose and stop suddenly, you can have really high blood pressure transiently. So we do warn that if you're on that for a while, it's not working, don't stop it without talking to someone. Antipsychotics. So the most common ones used would probably be Abilify and Risperdal. Those though they're actually a little bit more effective in terms of head-to-head comparison and tic severity, more effective than the alpha agonist, the side effect profile can be pretty daunting. You do have to do some lab testing periodically. You can get gynecomastia, which is a development of breast tissue, which a lot of the boys are already getting teased sometimes for the Tourette's syndrome. They also don't want gynecomastia, weight gain. Botox is something that more commonly used in adults. I have been trying to get it implemented here a little bit more, and it has been a little bit difficult. Topiramate is actually kind of an exciting, slightly more frequently used one recently. Head-to-head, it actually looks like its data is as good as around the antipsychotics. Now, Topamax is an anti-seizure drug. This one, I would use this in someone who has headaches and Tourette's. This is a very good headache medication as well. And it reduces tics by about 40%. So it can be helpful if someone happens to have headaches and tics, and I've seen it be pretty effective occasionally. Non-medication, I'm just going to briefly talk about this. So CBIT, Comprehensive Behavioral Intervention for Tics, is a I might just skip this, but we will have so much on this later. The reduction is phenomenal in tics. It actually is much better than medications, and the improvement is actually there whether or not you're on medications or not, which I think is an exciting feature of CBIT. So when I have someone in, they're new to this, what do I tell them? What do I tell the average family or kid that's in my office? So avoid escapism. So this is there's this delicate balance, I think, between making accommodations for kids with tics and Tourette's and avoiding escapism. Escapism means you get out of things, or you don't have to do things, or you get certain favors because of your tics. And you want to avoid that because that's creating that positive dopamine. You're getting some sort of benefit from doing this movement, and that's going to actually habituate that even more. So you will hear families say, like, we don't have them, if they're having a really bad tics, they can have dinner in their room, and that's actually not okay. They can take a break. So that's the accommodation, but they don't get to be excused. They still have to complete the same amount of homework, the same tasks, but do they get certain things to allow them to make that a little bit easier? I think that's fine. We don't ever punish or shame children for tics. This truly is something they can't control. Telling them to actually stop or punishing that makes it much worse. And that negative reinforcement is still reinforcement. We want to avoid that. And I only threw number 3 in there because a lot of people will say, like, what diet should I do? And the answer is like any that's healthy. A variety of foods, don't avoid any, don't go crazy. Just good old, whole foods, try to minimize, processed foods, but we all should. So help find your way, for your child to relax. That's a huge one that isn't involving screens. So screens are actually very stimulating for children. They can be a little bit relaxing for adults, but the way that their brains are wired, they actually need non-screen relaxation time. Support groups are great. Ergo, Jeff. Children with tics should not be bullied. I would, Jeff can offer some education to schools as well. And they may need special education assistance, maybe like different seating arrangements, additional time for testing. But again, that's not, they don't have to do tests. They don't have to do homework. So they can maybe have some things set up to individualize their environment to like maximize their success. Okay, moving on to something. So 2 years ago, like fall of 2020, I remember one of my colleagues comes up to me and says, Chelsey, there's this funny thing. I'm in charge of all the referrals, and I have seen this huge increase in teenage girls coming with tics. What is that? And I was like, I don't know. And this is when I started to take on this role as doing about 25% of my time in tics and Tourettes. So we had a huge uptick, pardon the pun, in kids with functional neurologic disorders, namely teenage girls, most particularly. So a functional neurologic disorder is someone that has neurologic symptoms where the cause or the etiology to those symptoms is not neurologic, it's actually psychological. So the age of onset is usually middle adulthood, but actually can affect kids as young as 6. But I would say frequently it's more in the young adults, teenagers that we find it. Sex ratios, females are affected more often than males in both children and adults. In large studies, the percentage of females is 60 to 90%. So yeah, sorry, those two statistics kind of argue against each other. In younger kids, it's similar in sex, but the older you get, it's more likely to be female. So this is a study, is this one? I'm forgetting where this one came from, but so this was one of the first ones in July of 2021. Yes, I think this is the one out of Calgary. This was phenomenal and helpful. And I would recommend looking at this. You don't need to get in the nitty gritty of this, but basically they saw that, we are seeing this huge increase. They are females. This is actually an adult center. So they had young females come in, which for us in pediatrics, this is like teenagers, older kids. And they would have an abrupt onset. So typically when you ask someone with tics and Tourette's, you'll say, when did your tics start? And the parents will say, I don't know, first grade? Was it first or second grade? I don't know. He did the sniffing thing, maybe first grade, maybe summer. I don't know. In kids with functional neurologic disorders, they were finding that we would say, when did it start? And they'll be like Thursday at 2 o'clock. It was a sudden, abrupt, or and maybe not even a day and a time, but that week of, like finals or something. There was a sudden, they could tell you to almost the day that it started. And whereas most kids, as we talked about, will start with having something kind of small in the face, it goes away, then something new comes up in the face, it goes away. These kids were having abrupt onset of multiple tics. So, and they were having very big tics. So most tics start in the face and they one at a time, they come and go. Whereas these kids were having chest thumping tics. They were stretching, huge, big movements, huge, big vocalizations. They would have many tics all at once starting on one particular day. So they also tended to have higher scores on all mental health symptom self-report measures. And the suspicion was that this may have been related to COVID-19, perhaps being on screen time too much, perhaps isolation, perhaps increase in depression. It was hard to say exactly what drove this. This came from the Tourette's Association. I think it came out in November of 2021. And again, they kind of compared side to side. Typical tics, again, male in the majority, 4-to-1, childhood onset, age 5-6, simple tics in onset, that's the early on they had simple tics, and they have a premonitory urge. In functional neurologic disorders, we are finding they were female in majority, teenagers onset, so 13, 14, 15, they would have very elaborate tics at the onset, and they often describe no premonitory urge. I like this one a lot, and I think we got a little weird about this one at one point in clinic, but there was a panel that took movement disorder specialists and actually had them watch TikTok videos where the hashtag was Tourette's syndrome, and they found that the frequency with which people were having coprolalia, self-injurious behaviors, though those things are things we infrequently find in kids with typical tics, this was like almost the majority of these TikTok videos. I will say, like, having now seen this and now having my own Instagram and now following some of these people, it's to the point where I sometimes I wonder if these people don't have functional or neurologic disorders themselves, but I worry that what they have are fictitious, and that they now sell hoodies and stickers, and they consider themselves neurodiverse, and they're doing these videos that to me are not they do not meet the typical tic or Tourette pictures. So it is a really unfortunate thing. And while a lot of parents, when I talk to them and say, I think that this might be what it is, they'll say, well, they're not on TikTok, they're not on YouTube. And at this point, especially this far out, I would say it's so pervasive in high school, in middle school, that I don't even think you necessarily need to have a social media account to be exposed to this, because it is becoming so common. And so as opposed to asking, what social media account do you have, I'll say, who have you seen that's done this? And they'll be like, oh, my friend, this friend, Jackie or something from class. And this quote at the bottom is a good takeaway. We believe this to be an example of mass sociogenic illness, which involves behaviors, emotions, or conditions that spread spontaneously through a group, meaning teenage girls more particularly. I've seen it in a boy. So again, this is kind of the same thing. This is the second study that looked at it, and they said, whereas coprolalia and self-injurious behaviors, there's a lot of chest thumping and like hand clapping. That's a really common one in this group of people. Though self-injurious behavior and coprolalia, which is again the obscene language, is only infrequently encountered in typical tic disorders. They're present in the overwhelming majority of TikTok subjects, and I cannot, having watched this, I got TikTok on my phone, and then I watched a few of these, and I couldn't do it anymore, so I had to take TikTok off my phone. I also didn't want to be a 37-year-old with TikTok, so there's that too. Too old for TikTok. So what do we do if they come in to the clinic and I say, well, this is what I see in a typical tic patient. I don't think that's this. You had a sudden abrupt onset. You ended up in the emergency room the day it started. That's also a red flag to me as well. Why, the difficult thing is, so I don't have a test. Like, I don't have a needle I can put in your arm. I don't have blood work I can do. I don't have an image I can do to your head to tell me what is a tic and what is a functional neurologic disorder or functional movement. I don't have that test. So I just hear the story and I say, well, this doesn't really fit like this. Why do I bother to go ahead and say, this is a tic and I think this is a functional movement? Because receiving a correct diagnosis will avoid inappropriate medical interventions. Functional neurologic disorders require a different therapy. They respond to CBT, not CBIT. Now, CBT is a little bit more of like a typical talk therapy. It's cognitive behavioral therapy, how your thoughts and behaviors affect your emotions. So it is a long road, but there are studies to say that, and so these kids sometimes need SSRIs. And again, medications for tics and Tourette's aren't helpful. So if you're on Abilify or Risperidone, you're taking medications that have side effects that aren't going to help this disorder. So the hard part is that well-intended responses by parents or teachers may worsen symptoms. For example, excusing someone from chores with functional tics or over-focusing on these may provide unintentional reinforcement, causing the symptoms to continue. So you'll see, and it's so hard as a parent, how do you watch your kid have these like self-injurious behaviors, cursing, hitting themselves, throwing themselves on the ground, spitting, those types of things, and not do anything, but it actually kind of is the right way to go about things. And that is not a talk for now. So why do we identify functional neurologic disorders versus Tourette syndrome? So why do I try to tell it to them when I can, though it is a very hard diagnosis to sometimes frequently talk about, is that the longer time it takes before you're diagnosed with a functional neurologic disorder means your outcomes are likely worse. There's actually a study out of, I think, just the Journal of Pediatrics that looks at kids with somatic complaints. So some of these functional complaints, if one parent buys into the diagnosis, the outcome of the child is better. So funny is you don't need to get two parents to buy in, but you need at least one parent to say, okay, I can see how this is now functional, and then they can kind of move on from that, and the kids actually do a lot better. So this is why we tend to try to give that diagnosis when we can. What's interesting too is a lot of people, will kind of push back on this diagnosis, but there was a review of 27 studies with a total population of 1,466 patients. The frequency in which we misdiagnosed a functional neurologic disorder was only 4%. So if it's functional, we're usually quite correct. Interesting as well as emotional disorders and personality disorders are not consistent predictors of functional neurologic disorders or outcomes.